Chandra-Mouli, who's here today from WHO, from the Department of Reproductive Health Research. And Chandra's been working on adolescent health at the WHO since, I think, 1996. So he joined WHO in 1993 and have been working on adolescent health issues in different departmental configurations since 1996. And prior to that, worked in India and Zambia with varying NGOs. And your interest is in evidence-based research and policy implementation and supporting countries in implementing adolescent programming, adolescent health programming. I've had the opportunity to work with Chandra for a few years, and Chandra led the special supplement of the Journal of Adolescent that came out a few months ago, and we actually had a launch here in Seattle of that supplement, looking at what works in supporting adolescent sexual and reproductive health and rights. And I think with that, I'll turn it over to you.
Thank you, Donna. Good afternoon, and thank you for coming in on a Friday afternoon. Over the next 30 minutes, I'm going to pose 5 questions and try to respond to them. The subject of my presentation is, why have so few countries moved from sound policies, thank you so much, and strategies on adolescent sexual and reproductive health to large-scale and sustained programs, and what has enabled those countries which have done so to actually break the mold. But I'd like to start with a little bit of the context. Last year, the world commemorated the 20th anniversary of the International Conference on Population and Development. That was a watershed event in public health and development. A remarkable consensus among 179 governments that individual human rights and dignity, including equal rights of women and girls, are a necessary precondition for sustainable development. This kind of language is commonplace now, but it wasn't 20 years ago. The ICPD was path-breaking in many areas, but one very important area was adolescent sexual and reproductive health. This was one of the first, or the first major global event, or global conference, where the sexual and reproductive health needs and problems of adolescents were tabled in such a manner. Now 20 years, thank you. 20 years have passed, and my first question is, how has the world that adolescents live in changed in the 20 years since the ICPD? For this segment of my presentation, I've just taken South Asia as a frame of reference. So 5 things. In these 20 years, there's been a remarkable transformation in terms of reducing extreme poverty. Much of this data is from the UN's Millennium Development Goals report. So in 1990, 53% of the people in Southern Asia lived on less than $1.25 a day. And by 2010, the rate had dropped to 30%. Of course, it's uneven, but huge decline. But of course, there's unfinished business. 1 in 5 persons in developing regions still lives on less than $1.25 a day. So huge decline in extreme poverty. Substantial increase in access to improved drinking water sources. In 72% of people in Southern Asia obtained water from an improved drinking water source in 1994. Sorry, the dates are wrong there. In 2012, 91% did so. And again, there are inequities. Rural residents and poor and minority populations had less access, but huge changes in access to drinking water. Another huge change was primary school enrollment. This has been one of the great successes of the Millennium Development Goals. In 1990, net primary school enrollment in Southern Asia was 75%. In 2012, it rose to 94%. There are, of course, many concerns about the quality of the education, but there still is a huge increase in the number of children in school. But again, as you can see from the slide, there are inequities and there are have-nots even within this important success. There's a rapid increase in mobile phone use. Whereas in the past this was, privileged access. I still remember, growing up in India, if you had a fridge or a telephone, you were very, very privileged, even if the phone didn't work for most of the time. And now, everyone has access to a mobile phone, and it has transformed people's lives. There's been a sharp decline in childhood mortality. In 1990, the rate was 126 per 1,000 live births. It's hugely declined. So huge changes have occurred, in the world in which adolescents live in. But let's look at how the sexual and reproductive health of adolescents has changed over the last 20 years. And in a nutshell, the answer is very little changes and patchy changes where these changes have occurred. I'm giving you 5 examples. This is from a UNFPA document, Marrying Too Young, published in 2012. And the bottom line in this document is, despite gains in selected countries, little progress has been made in preventing child marriage. There have been changes in the decline of child marriage in some regions of some countries shown on this slide. But overall, the decline has been very, very slow. The second of the 5 examples is adolescent pregnancy. In Southern Asia, births to women aged 15 to 19 declined. But the numbers are still huge. And in many parts of the world, Western Central Africa, Eastern and Southern Africa, Latin America and Caribbean, the rates are still very, very high. Another huge area is unsafe abortion. Thanks to misoprostol, we think there are changes occurring. But still, the numbers of adolescents who seek unsafe abortion and who either die or have lifelong consequences of unsafe abortion are estimated to be 3 million, over 3 million. Another area where we don't have trend data, but we're beginning to see data, is violence. This is from a London School of Hygiene and Tropical Medicine and WHO set of estimates published in the Lancet recently. So 1 in 3 women will experience physical or sexual violence by an intimate partner, and such violence starts early in the lives of women. And the last one is simple thing like menstruation. We've just in the process of publishing a review of MENACE, menstrual hygiene and menstrual health of adolescent girls in low and middle income countries. Many girls learn about their periods on the day their periods start. And even on that day, the information they get often from their mothers is too little and often wrong, because mothers carry a baggage that and information that they have acquired which is not always right. So huge problems with sexual and reproductive health of adolescents. I mean, there are many reasons for this, but one reason, and that's the subject of my presentation today, is what's the state of country-level work on adolescent sexual and reproductive health. In 2012, at the Commission on Population and Development, Shireen Jijiboy made a keynote address which Then she wrote up this and published that in Reproductive Health Matters the next year. And her key message was, while many countries have developed sound national policies and strategies and implemented pilot projects, much more needs to be done to fulfill the promises made in the ICPD. So policies and strategies in place, sometimes policies and strategies taken from one country to another on a Word document and with some tweaks made into that for another country, but very little action. And then last year at the Commission on Population and Development, the UN Secretary General tabled a report that had been prepared by UNFPA, assessment of the status of implementation of the program of action. And one of the messages is most adolescents and young people do not yet have access to comprehensive sexuality education, despite repeated intergovernmental agreements to provide it, support from the UN system, and considerable project-level experience in a wide range of countries and research. So, consistent message from different sources, from academics, from the UN system. And this is, the previous slide was about sexuality education. This is from a brief published by the World Bank last year, and October 2014. If you see the last line, it is the lack of access to demand for knowledge about health services among sexually active married and unmarried adolescent girls. So quite a sorry state of affairs when you compare with the huge progress made in child health and maternal health, of course to a limited extent when you compare with child health or tuberculosis or even access to antiretrovirals for HIV. So my fourth question is, why have so few countries moved from sound policies and strategies to large-scale and sustained programs? The report of the Special Rapporteur on the Rights of Women in Africa, tabled a couple of years ago, points to some of the answers to this. And the report says that in spite of the commitments made, negative social, cultural, economic, and legal factors continue to threaten the lives of and health of large numbers of women and girls. So one of the points they talk about is political will required to promote agendas and facilitate processes that may have difficult and contentious elements. So this is my first 2 points. One is inadequate commitment. When you have huge fires burning, and fires could be childhood mortality or maternal mortality or HIV. Adolescent sexual and reproductive health is talked about as one of the many priorities, but is not given the attention it needs. Often the focal point for ASRH is a woman. Often it's a low-status woman, often with an annual budget of a couple of $1,000s a year to run one meeting or something like that. So token programming and huge amounts of discomfort. I think in the World Health Assembly, when you have the Minister of Health of India or Ghana or Nigeria or Guatemala stand up to say, we don't want our girls to die of abortion, they mean it. But they are not prepared to give contraceptives to unmarried adolescents. They're not prepared to increase access to abortion services. So there is a huge amount of discomfort in dealing with all these issues of premarital sexual activity, access to abortion services, emergency contraception, even sexuality education, and even in the USA, it's not just Uganda, India issue. Statutory sexuality education is not in place even in England. So there are still huge parts of the world where these issues are no-go areas. Or there are areas where there are no laws. Nobody wants to talk about these things. Nobody wants to dirty their hands with dealing with these issues. There are no votes to gain and only votes to lose by touching these issues. And weak capacity. There's a considerable amount of experience in the NGO community, but they're often not there in the government. And so then what happens is you have line items and budgets to be implemented by the government, and you have often a child health focal point or a maternal health focal point assigned to be the adolescent health lead, or they're given additional responsibility to address adolescent health. And the UN comes in and does a 5-day workshop and goes away, and it's really a waste of money. Better to have a holiday in Thailand. These short workshops like these don't achieve anything, as we've seen in country after country. You know, these capacity building to deal with sexuality education needs much more than these short 5-day workshops. There's no money. I mean, we've seen with PEPFAR and we've seen with the Gates Foundation grant for immunization that when there is serious money on the table, it attracts people, it builds capacity, and programs move. There's not been serious money for adolescent health programming. HPV is bringing in money. Child marriage now is a priority issue, and the Canadians, the British, and others are putting serious money on the table. But this is for the first time. We're beginning to see some serious money for programming for adolescent health, and no real accountability. I've seen ministries of health representatives squirming when national data, statistics, the league tables are published. And nobody really is held accountable for poor progress on adolescent sexual and reproductive health. And Margaret Chan, Director General, often says if it's not measured, it's not done. And it's clearly not measured. Yeah. So this is why I have so few countries. And I'm going to give you 2 examples. You know, this is from Egypt. You know, 2 steps forward, 1 step back. This is from a policy brief from the Population Reference Bureau. And, you know, while you have a look at that, the basic point is this is the story in many, many countries. Somebody passes, formulates a policy, starts a strategy, someone else comes along, throws out the baby, the bathwater, and everything around the bath, and starts again. So, you know, you have lots of going forward, coming back. India is a very good case in point. You know, good progressive people started with sexuality education. A small, vocal, and influential minority protested against Hindu culture, against Indian culture. Virginia was in the WHO office in India, so she knows the kind of issues that come up. And so, you know, when faced with that, a couple of state governments said, no, we're going to move. We have understood the issues, but most don't want to take the risks. And then what you have is issues like this. You have the Bangladesh Prime Minister coming to the Girls' Summit in London last year, making all the right noises, and then saying, I'm going to reduce child marriage in my country. And then she goes back and says, the best way to reduce child marriage in my country is to lower the age of marriage. Then by that, we reduce the number of girls who are married underage. So huge political battle. So Kofi Annan, who's the chair of the elders, group of 7, you know, respected statesmen and stateswomen, wrote to her, and this is the open letter published on the Girls Not Brides website. So this is the kind of problems that you see in adolescent health programming that have really stifled programs. So then the question for us is, are there any countries which have broken the mold? You know, so do we only point to failures, or are there any countries which have done something that others have not? So what we started to do was we started this work with 2 questions. Are there low and middle income countries that have put in place sound, large-scale and sustained adolescent sexual and reproductive health programs? And we have operational definitions for those terms, but I won't go into them now. But, you know, have countries gone beyond boutique projects? And, you know, if they have, what factors enable them to do so. So that was a line of work we started about 2 years ago. We took the Center for Global Development published a set of 20 case studies, 25 case studies, I think, proven successes in global health. And we used a modified version of their criteria. These countries would fit into our positive deviant countries if they had addressed a public health priority for adolescents, if they had implemented them at scale, if their programs were sustained, and if they demonstrated some results, some results. No dramatic declines in, HIV or adolescent pregnancy, but, just any results, tangible results. And we identified quite an interesting spread of countries. Unlikely countries, Pakistan. Pakistan is in the news for all the wrong reasons, and you'll see in a few minutes that, they've done things that India hasn't done, which is liberal democracy and does not need to deal with the Islamic fundamentalism that blights Pakistan. But, and you see a mix of countries making progress. Nigeria, again, for all the wrong reasons, it's in the news, but it's done more in scaling up comprehensive sexuality education than Ghana, which is considered a poster boy for public health. So one of the positive deviant countries is Estonia. And what we've done is, over the years, over the last 2 years, we've been working with people in these countries to document them, how they've done this work. So I have these papers here, but Estonia, at the time the Soviet Union ended, they were looking for new ways to do things. They compared the statistics of adolescent sexual and reproductive health in their country with Western European countries and found that there was a huge need to do something. So they set up a youth clinic in '91. Over 9 years, they developed a national network. They developed a national sexuality education program. They managed to get it into health insurance funding. So they did not need to depend on outside funding. And the twin initiative coincided with a steady decline in both pregnancies, abortions, and STIs. Now, this kind of data we don't have in most countries. Nigeria, after an extensive consultative process, just want to mention that this paper on scaling up of sexuality education in Nigeria was written by Sylvia Oinoka, who was a student in University of Washington in Donna's class, who came and did an internship with me. So after an extensive consultative process, a national policy was made to scale up life skills, family life and HIV education. By 2012, it had been introduced to more than 30 of the 36 states in the country. And well-done studies in some states have shown improvements in knowledge, understanding, and reported behaviors. So these are two examples of countries where, of these positive deviant countries, of what they accomplished, where many, many others have not. Now we looked at what were the factors that enable these countries to do this. We used a framework developed by WHO and a group called ExpandNet, which teases out the scaling up process to look at what is the innovation being scaled up, who is the resource team guiding, inspiring, driving the scaling up, who's the user organization in the country who's actually doing the scaling up work, what's the context in which this is happening, the economic, social, political, cultural context, and then how is this managed, and who's paying for it, who takes the everyday decisions, how is this being advocated for, how is this being communicated. And I've given you now 2 examples of what it took to do this. I've taken England and I've taken Pakistan. Now, England has reduced teenage pregnancy to 1969 rates. like some of your states, Colorado is one of them. England, when Blair came into power, one of the agendas he had was social marginalization. He wanted to reduce social marginalization, and he had put a huge amount of resources for that work. The teenage pregnancy group somehow managed to hook into that agenda. So there was a window, and they hooked into, managed to communicate to the Blair government that this was the issue to address. They developed an evidence-based strategy and translated it into practical guidance for different players. There was strong leadership from the national level to the provincial level to the 150 local government areas. Data was used to hold officials responsible. For instance, 5 years into the implementation of the strategy, they found that there was progress across the board, but that there were some areas where there was much more progress than others. So they did a deep dive review, taking 3 areas where there was progress, 3 districts where there was progress, and 3 comparison districts where there was not enough progress, and found that in the poor progress districts, there was cherry picking. They picked a few agenda items and did it, and there was no systematic programming. So they translated guidance into prescriptive programming, no more democratic approach. If you want this money, you have to do this. You can then, after 3 years, talk to us about what you want to tweak. But for 3 years, this is what you do before you show results. And data was used to shut out piecemeal and token programming. And the results are there to see. So this was, of course, a government-led, people from the cabinet, ministers from the cabinet were assigned to oversee local government areas where progress was slow. Pakistan, completely different approach. You have a government which has too much on its hands. Even the UN agencies don't want to touch sexuality education because they'd rather focus on girls' education. They did not want to be seen associated with something that that might be seen as dirtying their hands. So a group of NGOs have led the effort. They perceived the need for life skills-based education. They were motivated to implement it. They were insiders, so they knew the politics, they knew how to speak in the local language, both literally and figuratively. They were able to advocate, they were able to raise money, they had connections both inside and outside, and they were able to move the agenda. They have now been able to scale up, as we've just published in this paper, programming that even liberal countries have not been able to do. By keeping their head down, navigating the politics carefully, bringing moderate Muslim religious leaders on board, and moving quietly without making a fuss. Every once in a while, there's a court case, and someone says that they are corrupting young people, and they quietly go and fight those court cases with a whole strategy to do that. That brings me to my last slide. We've identified, we started off by, the ICPD and where are we 20 years from now, and identified a small number of countries that have moved on. It's a retrospective analysis of a small number of countries. And retrospective analyses like these can be flawed because you can pick attributes which may have been there in other countries which didn't achieve those results. So one of the things we want to do is, as we identify these attributes, we want to then go and look at countries where no progress has been made to see whether they had the same attributes. Political leadership. I just want to share with you this wonderful set of papers by Jeremy Schiffman. He did a similar exercise, and there are 2 or 3 other subjects where they have looked at this. So what Jeremy Schiffman did was, a few years ago, 2007, he looked at countries, this was in the early days before this high attention to maternal mortality reduction. He took those countries listed there on the second line, and he looked at which ones addressed um, maternal mortality more seriously than others. And what he says is among factors that shape political priority was international agency efforts to establish a global norm. So clearly the outside change agent role is important in maternal mortality as it is for adolescent sexual and reproductive health. But that's not enough. You need money and technical inputs. You need cohesion among national safe motherhood policy communities. So you need the driving force from the outside. You need money and technical inputs. You need a community inside who come together. And you need national champions who get up every morning and want to address this issue. And you need to use evidence and emotions to convince policymakers that they need to do this. Like UNICEF often says, why this needs to be done, what needs to be done, and this has been done to be able to show policymakers that something can be done and it can achieve results. So some of these set of factors have to come together. For what he was able to show is that in some countries like Honduras, this was in place, whereas Guatemala, this was not in place. At that time, clearly India was in the bad boys category. Things have changed now, and clearly this is because of a combination of these factors. So just to close, what we see is in a small number of countries, a small but growing number of countries, a set of factors are coming together to move adolescent sexual and reproductive health programming from pilot projects run by NGOs, small-scale, time-limited, piecemeal projects into large-scale and sustained programs. And often this is because of pressure from the outside, but clearly one of the most important determining forces is a group of strong change agents from the inside who know the subject, know the politics, who know what strings to pull and what buttons to press, but who get consistent support from the outside to move the agenda. We need to do things differently in adolescent sexual and reproductive health than we have done. And we have to learn from the failures, but we also have to see from these, emerging successes that there are ways of doing things that we have not done as well before. So thank you very much. What I have is copies of the papers from Pakistan, Estonia, Nigeria. Several of the other papers are in various stages of development. So the idea is once these 15 countries' case studies come together, we want to bring them together, both to draw out, as we are doing now, the elements from them, but also to showcase that, despite resistance, and even in the most difficult circumstances, you can take these issues and address them. But you need new ways of doing them. For instance, in England, Tony Blair appointed Alison Hadley, who had been running the Brooks Center, an NGO, to head the National Teenage Pregnancy Program. So you need an NGO person leading the national government effort. And those kinds of partnerships you need, those kinds of expertise needs to be drawn in to make the difference. Now, King, you talk about Peru and how they've done, innovative work on STIs. And we need more Perus and we need more countries like this to say that the situation is not hopeless and that you can bring about change and countries are bringing about change.
Well, it helps to have somebody with your enthusiasm and energy.
Thank you.
One thing I didn't hear you stress was the importance of educating young women to higher levels and the impact that has on both their own well-being and that of their children. There was one study that was done by one of our faculty, Emmanuel Agakidu, that systematic analysis or review and concluded that 50% of the increase in child survival could be attributed to increasing levels
Yeah, one of the, I'll show you a slide that we've just done we just published a study disaggregating first births in adolescents in 3 East African countries by, I'll show this in a minute, reviews, secondary analysis. So as you rightly say, King, in 3 East African countries, what we did was we disaggregated data on first births, and we looked at age, educational level, economic level, urban rural residence, religion, and clearly, as you see in the conclusion, adolescent first births, particularly at the youngest ages, are most common among the poorest and least educated, and progress in reducing rates, because in these 3 countries we had 3 DHSs, and we were able to show that the trends in this group was the poorest. So one of the papers in this Journal of Adolescent Health Supplement is creating an enabling environment for adolescent sexual and reproductive health, a framework and promising approaches. It uses an ecological framework with the girls, their relationships, their families, their communities and societies. So clearly one very, very important thing is keeping girls in school. But while the MDGs have succeeded in increasing primary school enrollment, still girls leave school around 11, 12. And particularly in the poorest parts of the world, in South Asia and in sub-Saharan Africa, the gender gradient in primary school is declining, but in middle school and secondary school, it's still very wide. So we need to keep girls in school, but that's a very complex issue. Girls are not in school because the road to school and back is unsafe, because schools don't have toilets, and if they need to use their toilets for changing their sanitary napkins, there's no toilets there. And there are many reasons, but I think there's lots of effort to try to keep girls in school. I think I think for many, many development agencies, that's one of the very big priorities for health, but also for various reasons. Please, ma'am.
I know there's a lot of interest now on the younger age groups,
Yeah.
of the 9 to 12-year-old girls, given access to them through schools and also with HPV vaccine and other interventions. So I wonder if any of your analysis looked at the difference in programming or country successes with a focus on that age group, in addition to older girls, but specifically with that age group, and what kinds of programs are working and are they being evaluated?
Thank you. We've just, again, I'll just take you through this. We're just doing a research project with Johns Hopkins University on looking at gender socialization in young adolescents to see how it affects the emergence of healthy sexuality. This is before sexual activity begins in the majority of adolescents, and then to see how it affects sexual behavior later on. And we're doing it in 15 countries with a whole range of funding support. But the answer, that doesn't answer your question. Your question is, how well are young adolescents being addressed? Most programs for adolescents address older adolescents, 15 to 19-year-olds, and even 20 to 24-year-olds. So the younger adolescents are generally not addressed. So essentially what happens is, after the child doesn't die by the age of 5, the next time this person is seen is either when they have a road traffic accident or when they're pregnant. Between 5 and 9 and 10 and 14, they're almost lost to the public health agenda. There's no particular interest in them. Most school health programs in the poorest countries of the world have collapsed. In the middle income countries and in the wealthy countries, school health programs are being strengthened. But for instance, this is another study we're doing to test whether we can deliver the HPV vaccine and use that to revive school health programs. Whether we can deliver the HPV vaccine with a complementary package of interventions such as visual acuity screening, iron folic acid supplementation, even basic health education. But I think Save the Children, there's a whole network now of organizations working now on very young adolescents. There's a network. And for instance, there's a very interesting study in Nepal by Rebecca Lundgren from Georgetown University, whose turn to do the dishes, working with young adolescents there to build equitable gender norms. We know that by the age of 15, many adolescent boys in many countries believe it's perfectly okay to beat your wife if she burns the food, if she back answers, if she leaves the house without your permission. They give for these 4 or 5 reasons. And an almost equal number of girls think it's okay to be beaten by your husband for these reasons. So there's a huge need to address these issues for health, but also for these kind of social reasons, these normative reasons.
So these efforts include then young boys?
Absolutely, absolutely, absolutely. You know, there's a lot of focus on girls, and I think that's important, very important. But for boys, and I think, you know, we see in the West at least, boys are performing worse in school and really need support. Completely different ways of dealing with boys. And you see this in the have-not community, growing fundamentalism, Islamic fundamentalism, trapping young boys with no sense of purpose and no sense of identity with their community. I think it's a huge issue. This whole issue of this rape of and killing of this medical student in India 2 years ago, there was a BBC interview. I hope you have the time to see this film. It's called India's Daughter, a BBC documentary which has been banned by the Indian government for some stupid reason. But clearly, this reporter interviewed the driver of the bus who had no remorse at all. Said, you know, if she had not protested, she would have gone away without being beaten up and killed, you know. So you're absolutely right. But we need to do more. There's, again, a growing number of people working with boys, but much more needs to be done. Yes, sir.
You spoke about the need for having national champions.
Yeah.
How effective are past agencies, for example, in Africa or South Asia, moving the discussion about drug education and bringing sex education out of a closet? Because I remember this in Uganda, where I come from. When HIV came, we thought that would create sex education would be global. But it looks like we're becoming significant as we've seen with HIV. What are your thoughts about that?
No, I think national champions are very important and they play a very important role. I mean, take Rwanda. Rwanda's Minister of Health is a PhD in adolescent health. And, you know, her commitment to and her knowledge of what needs to be done is very, very sound. So not only is there rhetoric, but she also knows what the girls' groups need to do, how they need to be delivered, what needs to be done. Like you said, how is it measured and how it's documented. Now, I lived in Zambia for 10 years, and at that time, Museveni was one of the great champions. I think he got hijacked by the born-again Christian agenda. He did some really great things with Noreen Kaliba coming out with Tasso, and they did some really good things. You know, whatever you say now about this, you know, zero grazing and the ABC strategy, they did some really innovative things, brave things. He was one, President Kaunda's son died of AIDS, and he talked about it. Museveni talked about it. These were all great leaders. We need more people like that. But not people, you know, we are just in the process of publishing a paper on what doesn't work in adolescent sexual and reproductive health. One of the things that doesn't work is large-scale public meetings where you build a shamiana, you get a political leaders, you get caps and T-shirts, your night poster, and you tell the community from tomorrow we stop female genital mutilation. So you spend $5,000, you tick off your activity done, nothing happens. Now, so we need champions, but we need champions who are there, who see that this work is done. And there are champions like that. But there are also champions who just come in for the, the big event when the press is there and then leave. But you need the champions who get up every morning and fight the battle that needs to be fought. Please.
One of the things that we've been talking about a lot is how universities interested in global health can be more helpful and more proactive in key strategic areas. This is one that I think, as you've highlighted so beautifully, is both underserved and incredibly important. From your perspective, what could people like us, sitting in a university that aspires to be one of the leaders in global health, do to help with this effort?
So I have a very easy answer to that. Now, we evaluate. We evaluated a program in Jharkhand state of India. Jharkhand is one of the new backward states. It came when Bihar was broken up. So which you take all the indicators, health and social indicators, they are far below India's average. So the Packard Foundation supported Engender Health, which is a US NGO, not to implement a program, but to support a state government to implement the Adolescent Sexual and Reproductive Health program. So those were the objectives: to improve supply of services, to improve demand, and create an enabling environment. We evaluated their program, and essentially the bottom line is, using a small amount of money, the Tarunya project was able to leverage the state government's activities. They actually got more money from the central government. They spent more money. They improved the quality of services. It was patchy. It was, warts and all, but it was really improved, good quality programming. For me, I don't think that in sensitive matters like abortion, gender-based violence, adolescent sexual and reproductive health programming, low and middle income countries will move without hand-holding by NGOs and universities. A combination of internal and external change agents. You need them. Engender Health, they were able to get Xavier's Institute. There's a university in Ranchi, the capital city. They were able to get the university to support monitoring, to support documentation. And their presence was very good because if you've worked in India, you know very well how much pressure is there to pay bribes. They had no money to pay bribes. They had no capacity to pay bribes. They were there as technical experts. They were able to provide support on demand, and they were used by the state government to support them and to strengthen their programming. Now, that's what I think needs to be done. All this national level people say all the right things. You bring them to the family planning conference in Ethiopia, or this year it's in Indonesia, they'll give the right, they'll say the right things, cite the right data, make the right speeches. But when you go to the subnational level, that's where the programming is weak. Many countries are moving into decentralization. There's very little capacity there for programming. And you say youth-friendly services, it doesn't mean anything. It means one-off training. And so universities, and I think international and national NGOs have, I think, a crucial role to play in taking the rhetoric and making it reality. Pakistan was NGO supported by Dutch universities. And I think really you need more of that. Just one last point, the Reproductive and Child Health Project in India is largely Indian government paid. They've spent millions of Indian taxpayers' dollars If you go to their website and look for ASRH programming, there are no monitoring reports, no evaluations. They've developed a new adolescent health strategy based on the ideas of a group of 8 or 10 people sitting around a table. No evidence-based programming. And what we need is more data, because without this kind of support from universities, from international NGOs, programs will remain where they are.
So, in the United States, my perception, not being an adolescent medicine person, is that actually there's very limited capacity and expertise in most parts of the country in adolescent medicine and health writ large. I mean, it's getting a little better, but there are not that many training programs. And so adolescent issues, including sexual and reproductive health, get rolled together either with slightly older women or with children, right? And adolescents actually are sort of different, and it's a critical age, as you alluded to here, for behavior formation for good or for bad. And so in addition to the capacity building relating to monitoring and evaluation and implementation science and some of the other broad categories, I guess one of the questions is how much you see a need for developing in-country capacity related specifically to adolescents and their health and social needs in many of the countries you're working in. My sense is that there's next to nothing in many of the countries in which we work, but great interest.
Absolutely right. You're absolutely right. We need more capacity. And because I'm based in Geneva, I'm part of UTeach, a network of European professionals working on adolescent health. There's no pre-service training on adolescent health, even in most Western European countries. So I think this is an area where there's a huge capacity need. And so what the UN and I think international NGOs have responded to this is with 3-day courses and 5-day courses. And so I think you need to build capacity. In the way we're beginning to move now, there's a wonderful review paper by Alex Rowe from the CDC on how to build and maintain improvements in performance of health workers in low and middle income countries. So what he talks about is training, job aids, but also ongoing training. So for instance, in Moldova, what we have started doing is trained health workers, we bring them together every month so that they can share experiences, get a little bit of injection of new information, compare notes to identify problems, and then go back and come back afterwards. So I think we need everything. You need the pre-service courses in medical school and nursing school and education. You need in-service training, but you need learning by doing and mentoring. So I think you need a combination of that. The problem is most training programs have been 3-day, 5-day workshops, pulling people out of work, and everyone loves that. You get a per diem, you don't work for 5 days, you're not at all obliged to do anything when you go back. And 60-70% of donor funding is spent on training.
So what about leadership training for this? I mean, if you're serious about this, kind of having people actually train longer term in a bi-directional way, either some coming to the States or some of our folks coming in working side by side over a year or two, to build the leadership for those people that are doing the 3 to 5 day courses. I mean, is that the kind of thing that you think is necessary, and if so, where's support for that kind of?
No, Donna and her husband Charlie have been working, for example, in Ghana over many years. And I think those kinds of partnerships are beneficial on both sides. Sometimes what happens is these partnerships are not partnerships of equals. I participated in a meeting of African researchers. They said, we have a partnership with this Canadian university, but they have the money so they can send their students. and we can't go there because we don't have money. On paper, it's a partnership of equals. In actual practice, it isn't. But I think partnerships like that are important. Are important. They need to be built. They need to be supported. I don't know where the resources for that will come from. I hope one of the points I'm trying to make is we need a new way of doing things. If we want to move adolescent health programming, we need to engage universities indigenously. I mean, Nigeria, for instance. People say that, Nigerian researchers say it's easier to go and give a presentation on their research in Copenhagen or London than in Abuja. And I'm sure that's true in India as well. First of all, the national government authorities are not interested in the research, especially if it is done by a local researcher. If a white man comes from abroad with a lot of money, they are interested in listening. But if a Nigerian researcher in Nigeria or an Indian researcher in India comes and presents research, they are not interested. So, how do you create a climate where research is respected, where researchers can go? I mean, all these things are difficult, but needs to be done. My brother lives in Singapore. What he tells me is that once a month they have a closed-door meeting on a particular topic with a few politicians, a few academics, no minutes taken, nobody is supposed to report on any discussions that happen there. So they can take an issue, discuss it threadbare, and everyone goes away a little bit more informed about what happens. But, like I said to you, the Indian government's new adolescent health strategy developed without any research on what has been done. And in the meeting where it was launched, state government officials from many states said, this is nonsense, this won't work. But somehow people from there, Professor Bob Bloom from Johns Hopkins was there saying all the right things, saying things like, if it has not worked in 10 countries, don't believe it's going to work in your country. But you need people like that who can say these things and who can push the agenda. And to do it in a way that is not seen as patronizing. Because you can tell Malawi what to do and they'll do it. But the middle-income countries won't, So you need somehow to talk to them in a way that they see as is respectful but actually tells the truth at the same time.
So with 30 seconds left, I think we should all give you our resolution that we will never try to teach a 3 to 5 day course. Thank you for that fascinating presentation.
Thank you, sir.
I'm glad that you haven't given up on trying to make changes once people have reached adolescence. There are those like our social development group here at the university who feel that once they reach adolescence, the horse is out of the barn. And you really have to start earlier when they're, babies and ongoing on a continuing basis. But I think your enthusiasm about interventions at all those ages is great. So thank you very much.
Thank you, sir. Thank you very much.